So I wanted to talk today to focus a little bit on a couple of things. These are some disclosures, just educational projects, nothing that's of direct relevance here. And so we're going to talk a little bit about developmental or pediatric neuropsychiatry and just give a little bit of an introduction to that and talk about ways in which features of a neuropsychiatric approach could be brought to thinking about working with individuals with cerebral palsy. And also in a sort of focusing less on the neuropsychiatry and more on CP itself and making sure that people are aware, especially as adult practitioners who may not have worked as much with folks with neurodevelopmental diagnoses, so that you all can be a little bit more prepared. Dr. David Silberswag has a wonderful quote from a recent textbook that I'll just read, defining neuropsychiatry. So, the neuropsychiatrist is ideally suited to evaluate and treat patients who have abnormalities in perception, cognition, emotion, and or behavior due to a known psychiatric or neurological disorder, due to the simultaneous presence of or interaction between psychiatric and neurologic disorders or their treatments, and associated psychosocial elements, or due to an unknown underlying brain condition. I think this is a wonderful description of neuropsychiatry. It details an extremely broad mandate, but I think gives you a little bit of a sense. Now, for folks who may or may not know or may be interested, there are plenty of adult behavioral neurology and neuropsychiatry fellowships in the country. Dozens. There's formalized training. You can do a residency in neurology and or psychiatry. Some folks do both. Then you do a behavioral neurology neuropsychiatry fellowship, and you come out as a behavioral neurologist or a neuropsychiatrist. So there are formalized routes to doing this kind of work. Within pediatrics, there really are not. There's not a similar pathway. There are lots of children and young adults who have congenital, acquired, or other kinds of neuropsychiatric diagnoses. And clinicians from an extremely broad range of backgrounds will be working with them to manage psychiatric, neurobehavioral, cognitive, and other related symptoms. So you can see you could have somebody in pediatric neurology, psychiatry, developmental peds, neurodevelopmental medicine, pediatric palliative care, physiatry, or PM&R, right? So it's a much less direct pathway, which creates a lot of challenges in terms of really understanding and working with folks with neurodevelopmental diagnoses. So in adult psychiatry, adult neuropsychiatry, people are interested in thinking about neurobehavioral correlates with the brain, right? So regions of the brain, circuits that may have a correlation with certain behavioral symptoms. So you might think very differently about somebody who's got a frontal lobe injury, who develops apathy, how you would diagnose and manage that, compared with, say, how you might diagnose and manage amotivation or apathy-like symptoms in somebody with depression, right? You can use that in terms of approaching diagnosis. You can use that in terms of treatment. And there's just no end of examples you could use. In pediatrics or in development, and I'll use developmental and pediatric neuropsychiatry a little bit interchangeably. We can talk about that later if people are interested, but apologies for any confusion. So when you're working with kids who have neuropsychiatric diagnoses or young adults with neurodevelopmental conditions, it's quite different because you are looking at injuries which in an adult may produce a fairly stereotyped syndrome, right? If you have somebody who has a left MCA territory stroke, you can have a general idea of some of the behavioral or language or cognitive symptoms that might occur. In kids, the results of that injury are going to be very different if it was prenatal versus at 2 versus at 8 versus at 12 or older. And so this makes prognostication much different and I would say more challenging in children. Two people could have what look like an identical injury. One could come out with an IQ smack dab in the middle at 100 without any discernible sequelae, and another could have a kind of devastating injury. So it's very hard to easily and clearly kind of foretell how an injury will play out in a way that's very different from in adults with like an acquired neuropsychiatric condition. In addition, we've got just the superimposition of typical development. You've got puberty, adolescence. You have the kinds of stresses that young adults and kids are faced with. You have traumas and exposures that are so different during childhood or during key developmental phases than in adulthood. So these are things which make significant differences in terms of approaching people who are children at the time of an injury, or folks who you all might see more, adults who've had a childhood onset injury, right? You see somebody at the age of 30, 40, 50, but they had some injury that occurred when they were 2 years old, 10 years old, 12. And it's a very different thing to attend to than somebody who had an adult onset injury. Finally, thinking about transition to adulthood is crucial and extremely complicated, and is something that we really struggle with, I would say, globally, and we'll talk about that. So what are the goals of developmental or pediatric neuropsychiatry? We want to integrate underlying knowledge of an underlying disease, or uncover it if we don't know it yet, with an understanding of typical or disrupted child or young adult neurodevelopment, and associated psychiatric diagnoses that could go along with a particular diagnosis. We want to use that to be able to anticipate a potential differential diagnosis, complications or comorbidities related to a disease process, psychosocial or other risks that might be specific to a particular population with a particular neurodevelopmental or neuropsychiatric disorder, and then challenges that we might be able to anticipate as people go through transitions in life. And then using all that information, we want to be able to manage the underlying medical, neurological, and psychiatric aspects or workup where appropriate, target neuropsychiatric symptoms, and then collaborate with providers and other specialties regarding management of an underlying disease process or medical comorbidities that are related to an underlying neuropsychiatric condition. So when you think about adult neuropsychiatry or behavioral neurology, you're often thinking of neurodegenerative diseases. Does somebody have cognitive symptoms because of Parkinson's, because of Alzheimer's, because of frontotemporal dementia, and different subtleties that help you tease those out. And there are plenty of other conditions that adult neuropsychiatrists treat, but that's kind of historically at the center of the field. Within pediatrics, this is just a short list of some of the conditions that we see and treat in our clinics. But you can see it's a very wide range of systemic conditions, acquired disorders like TBI, concussion, stroke, brain tumors or surgical trauma, neuroinflammatory conditions, epilepsy syndromes, sleep disorders, neurogenetic diseases. I have a particular interest in working with kids and their families around pediatric neurodegenerative diseases and neurometabolic conditions. So that just gives you a little bit of a sense. This is from a lovely paper by Margot Lauterbach, who's a neuropsychiatrist just down the street at Shepherd Pratt. That came out a few years ago. It just emphasizes, like, why do we care as psychiatrists about rare diseases? Well, for somebody to come into your office with a particular rare disease, the chances are going to be rare, definitionally. But there are a lot of rare diseases, and there are a lot of people. So there's actually an incredibly high rate that you will have patients in your practice who have rare diseases. About 1 in 15 people is affected by a rare disease based on the definitions we typically use. That's a very high number. That means you will see a lot of people with rare diseases, and many of these have neuropsychiatric manifestations, and about 3/4 present during childhood. So we're talking about a large number of patients. I'm sure you all can think of examples from your own respective practices of folks who have rare conditions that manifested with psychiatric symptoms, and that then became something that was part of your role to engage with. So when we think about cerebral palsy itself, this is a heuristic that I like to use when we're thinking about neurodevelopmental or developmental neuropsychiatry or pediatric neuropsychiatry. We're thinking about what do we know about the underlying disease and associated comorbidities. How do we think about this in terms of development and trajectory? What do we know about psychiatric comorbidities and psychosocial factors? And then how do we incorporate an understanding of genetics and other risk factors? So because we're talking about CP, and I would like you all to know a little bit more about CP, let's just define our terms. So this is an old definition, but it more or less works. CP is defined as a group of permanent disorders of the development of movement and posture, causing activity limitation that are attributed to non-progressive disturbances that occurred in the developing fetal or infant brain. So there are new developments in the field that challenge a little bit of this, but it's a good kind of overall summary. This is the most common movement disorder of childhood. 1 to 4 per 1,000 kids in the US have a diagnosis of CP. That's very common. Now, neuropsychiatric comorbidities are incredibly common for folks with CP, but you'll notice that did not come up anywhere in the definition. It's something that we really have a tendency to not think about very much. This is a image from Radiopedia. This is like kind of a typical image that we'll associate sometimes with cerebral palsy. This is periventricular leukomalacia, which is a little bit more of an association rather than something with a causal relationship to CP, though there's like some controversy and a lot to say about that. But these are different conditions or associated diagnoses that go along with CP. Intracerebral hemorrhage, infection, hydrocephalus, hypoxia and ischemia, brain malformation, neonatal stroke, chromosomal abnormalities or kernicterus. So these are all different things that are kind of have associations with the diagnosis of CP. And I find this a very helpful image and a useful thing to talk about because we forget about some of the brain correlations with things often. The typical language that gets used, though this is again getting more complicated and nuanced now, but we'll often separate forms of cerebral palsy into spastic, dyskinetic, or ataxic. Somebody with spastic CP will have brain on the contralateral side, particularly in the motor strip, affected. If somebody has quadriplegic CP, they'll have larger amount of brain involvement. They'll have motor cortex involved on both sides generally. If somebody has athetotic or dystonic or forms of dyskinetic CP, this is subcortical structures, so like basal ganglia. And if somebody has ataxic CP, the cerebellum's generally involved. So this is helpful just to like remind everybody that we're talking about brain things, but also to keep in mind that there are behavioral and other neurological correlates with these areas. And so knowing more about which area of the brain is involved can help you anticipate a little bit about certain features of psychiatric symptoms that might occur. So the literature base in terms of psychiatry and cerebral palsy is needs to grow. It's pretty limited. But studies show that up to 57% of children with cerebral palsy also meet criteria for a psychiatric diagnosis or have significant psychiatric symptoms. It is a very high number. We think mostly about anxiety, depression, and behavioral issues, which are the most common. However, essentially all psychiatric diagnoses are present at higher rates in folks with cerebral palsy. So we need to be much more aware of these comorbidities than we are. There have been attempts to try to break apart why this might be. Is it sleep? Is pain a mediator of this? Other social factors, things like bullying. And you can sort of parse apart a little bit how other of those features might be causally related, but clearly each of them is not the whole picture. Additionally, neurodevelopmental diagnoses are at a much higher rate. Up to 7% of people with CP meet criteria for autism spectrum disorder, intellectual disability, and 45%. Now, that's important because that means 55% of people with cerebral palsy do not have intellectual disability, which is a thing that I think as providers we often forget. It's very easy to bring all kinds of assumptions to the table when you're interacting with somebody who has cerebral palsy, especially if they have a communication or language disorder, like we can see in more than half of people. I have patients who have who are not able to speak, who don't have expressive verbal language, but have a normal range IQ. Our college students are able to speak multiple languages, communicating exclusively through eye tracking devices. So it is so easy for us to misestimate what somebody's internal experience is and really not understand, which makes us miss a lot of things, but from a purely clinical perspective means that we are really not appreciating the kinds of other challenges that somebody might be experiencing in terms of things that we could easily help with: anxiety, depression, mood disorders. So CP goes along with a lot of other comorbidities. Many of these can impact developmental trajectory. And I think within neuropsychiatry, especially developmental neuropsychiatry, it's really crucial for us to think about the layering effects of different kinds of injuries. So yes, having cerebral palsy predisposes to whatever, a certain percentage risk of major depression. But it also predisposes to other conditions. It goes along with prematurity. It goes along with epilepsy, which all carry their own neuropsychiatric sequelae and risk factors. So thinking just about one potential etiology of cerebral palsy, pediatric stroke, there's been controversy for years about is there a particular age where it's most protective to have a stroke in childhood? You might imagine it's better, it preserves most function, to have an injury when the brain is at its most plastic, so earlier on. You also might think it's better to have the most developed substrate and most kind of elaborated and developed neurocognitive function before it happens. And those are a little bit in tension, but you'll see there's a sense in which both are right. There's a window early on really across neurodevelopmental domain or neurocognitive domains. So it seems like having an injury like that during a period of peak plasticity is somewhat protective. Otherwise, the later the better. So this is really crucial when you see a patient who is 40 years old, has a history of childhood stroke. It's something very different for you to engage with that person and think about what might be going along with their experience if the stroke was in utero versus 18 versus, say, 6. And then we also forget, too, other things about normal development. So outside of individuals who are the most dramatically, motorically affected in their cerebral palsy, intellectual disability is a much greater mediator than CP itself in terms of social participation. So you'll see that for folks who have cerebral palsy but don't have intellectual disability, there's a little bit of a lag for them to catch up with same-age peers. But by 18, they essentially catch up in terms of social participation with their same-age peers. So again, things that we need to keep in mind in terms of our understanding of people's experience and planning and whatnot. Again, thinking about prematurity, and this is peeled away from the issue of cerebral palsy, there are associated risks to prematurity and certainly to extreme prematurity as well. And there are even sort of behavioral phenotypes that have been described specific to extreme preemies. And this can include things like a higher rate of anxiety, higher rates of attentional or executive function troubles. So again, these are things that very few of our patients have one thing going on. So you need to appreciate these different risk factors or protective factors as they're layered when we think about our patients, their prognoses and potential treatments. So when we think about neurological conditions associated with cerebral palsy, epilepsy, movement disorders, pain, and other medical considerations, sleep and implantable devices are all things that are just, as you kind of run down associated comorbidities, risks, or things that might come up for somebody with CP, these are very important. So epilepsy is extremely common for individuals with cerebral palsy. Over 40% of people with CP have epilepsy during their life. So if you don't consider the CP, you're thinking of epilepsy alone. People with depression have over 20% comorbidity, or people with epilepsy have an over 20% risk of depression, 20% risk of anxiety, 2.7% greater risk of ADHD, intellectual disability in a quarter, autism in a fifth. Right? So again, as we think about the layered different considerations and complexities as we work with patients who have something like CP or another neurodevelopmental diagnosis, incredibly important to think about these other factors. Spasticity, dystonia, and ataxia are things that come up very commonly for people with CP, as well as the concern about superimposed tardive dyskinesia. It can be a real challenge when you've got somebody who has a movement disorder who's then also on an antipsychotic, either for bipolar disorder, psychosis, or antidepressant augmentation. So teasing that apart is really challenging but important. And pain is incredibly common for people who have cerebral palsy. Up to 70% of people with CP describe experiences with pain. Spasticity is one that I feel like is just easy to talk about for folks who haven't worked in like movement disorder clinics, or if it's been a while. This is the velocity-dependent muscle tone increase from an upper motor neuron injury. It's a common source of disability, of pain for folks who have CP. And it's something that even a few years ago I think was conceptualized much more as a primarily neurological problem. But increasingly we realize that there's such an intimate relationship between spasticity and things like anxiety or mood, as well as medications. So you can get this very complicated interplay of somebody whose spasticity gets worse when they're anxious. They are on an antidepressant. That improves the anxiety, but it may in and of itself worsen their spasticity from a separate mechanism. So you end up with these very complicated interactions between psychiatric symptoms, movement disorder, and treatments. Insomnia, too, is something that we commonly see, where anxiety worsens it, but so does spasticity. So this is a not remotely as complex a diagram as it could be, but it gives you a little bit of a sense of the different kinds of considerations that come up with each of these potential experiences for somebody with CP. Pain, and again, this could be a talk in and of itself, talking about medical and neurological comorbidities in cerebral palsy, but orthopedic issues, pain especially, bone degeneration or pathological fractures, surgical pain. The number of patients who I've seen who come in with some kind of neurodevelopmental condition and an exacerbation that's called psychosis, bipolar disorder, mania, whatever, and it's caused by constipation or dental pain, I can't even tell you. They are incredibly common in folks who have underlying neurodevelopmental conditions. When you see a behavioral change for somebody, especially if they've got communication limitations, it's something we have to attend to really carefully. This is just something that's worth being aware of. You can end up with folks who have implantable devices for underlying neurodevelopmental conditions. It's really common if people have hydrocephalus, which can occur in people who've got CP pretty commonly, to end up with a VP shunt, a ventricular peritoneal shunt. Intrathecal baclofen pumps are very common for managing spasticity, and vagal nerve stimulators are used really commonly for epilepsy. So I like to try and get some public service announcements in there. Shunt malfunction is a thing that occurs not uncommonly in folks who have shunts. It can present as primarily a behavioral change. So I've actually had a patient with CP come in 2 times for the same complaints. The first time, impulsivity, behavioral dysregulation, irritability, and it was in the setting of, you know, what we kind of diagnosed as a broad constellation of factors: inappropriate educational setting, some underlying sequelae of the CP itself, some need for specific parental training, and untreated autism and ADHD. And you manage that, things get much better. And the person came in again not too long after, same symptoms, but this time it was acute shunt malfunction, right, which is a neurosurgical emergency. And so you can see the same cluster of symptoms from extremely disparate causes. So if somebody has something like a VP shunt in, they might present to you as their psychiatrist or somebody managing behavior in some other field first, before they present to their neurosurgeon or someone else in the emergency room. So it's crucial to keep these things in mind. And then finally, increasingly we talk a little bit more about genetics in conditions like CP, because as genetic testing improves, we're finding more associations with underlying genetic diagnoses and cerebral palsy. I think gone are the day where we more or less exclusively associated cerebral palsy with some kind of perinatal trauma or injury or anoxia. 23% of people in one study with cerebral palsy were found to have a genetic condition that was potentially causally related to the CP. That is extremely high. And so this brings us to a couple of things. Specific neurogenetic syndromes that might be associated with CP give us a particular set of behaviors and psychiatric symptoms to think about. So in addition to all the other factors that we thought about and talked about before, an underlying gene gives you other prognostic information. So for example, we've seen patients with all of these in our clinic, but 22q11 might be one that people are more familiar with. This is the old velocardiofacial syndrome, or DeGeorge syndrome. Makes up about 1% of people with schizophrenia. The rates of psychosis and meeting formal criteria for schizophrenia for people with 22q is quite high. So if somebody comes in with cerebral palsy, but they also have that mutation, that diagnosis, I'm going to have my ears perked up much more for psychotic-like symptoms or for anxiety that has more of a psychotic kind of feel to it than I would be otherwise. So having these underlying genetic diagnoses can be extremely informative and impact care a lot. Again, another PSA. This is from a paper that we just put out 2 months ago. Just in terms of thinking about genetic testing for psychiatrists. So this changes so quickly that a lot of organizations have trouble keeping up with formal recommendations. But essentially the standard of care for most neurodevelopmental diagnoses at this point is to do whole genome, whole exome sequencing. And so we can talk more about that later, but this really changed my practice, learning this fairly recently, and I think is really important for us to be aware of. I think we have a tendency to be less involved in that process as psychiatrists than we could be. And then finally, we really have to emphasize psychiatric and psychosocial factors for individuals with cerebral palsy or other neurodevelopmental conditions. So psych comorbidities, trauma, family dynamics, educational settings, peer relationships and emotional needs, education and employment prospects, and of course the challenges around transitional age are crucial. We forget, I think, often, especially if we don't work with families a lot, how often depression, anxiety, PTSD, and other things can go along with being the caregiver for somebody with an underlying neurodevelopmental condition. So just something incredibly important, because we're often, usually, almost always, working with family systems, not just with an individual themselves. And I think often we have this false dichotomy as we're trying to come up with the simplest possible explanation for symptoms. Like, oh, this is because of a neurological condition. No, it's because of trauma. Well, very unfortunately, having an underlying neuropsychiatric, neurodevelopmental, or other condition does not protect a person from experiencing emotional or physical or other forms of trauma or abuse. Rates of pretty much every adverse childhood experience is elevated for folks who have an intellectual disability or neurodevelopmental diagnosis. So it's something that we really need to keep in mind, especially if you're working with folks where there's an acute change and it's your job to diagnose or manage what's going on in an acute setting. So for like residents who are in the emergency room, I'm looking at all of you, because you will often get somebody coming in, from a group home or from some kind of setting where you see that they're in an acute change of their mental status and you don't know why. So it's worth really always keeping those kinds of risk factors in mind, in addition to the myriad other ones that we've talked a little bit about. And again, we need more in the research world on transitional age for folks with CP, but a nice meta-analysis recently looked through a large number of existing studies and found some trends that I think are not going to be a surprise to anyone, but we really need to keep in mind. So poor outcomes in transition are associated with housing instability, difficulty with relationship formation, high rates of hospitalization and low utilization of rehab services. Protective factors often include family participation, promotion of self-advocacy and efficiency, and crucially, like involvement of the adult team prior to transition to adulthood, which is something that we always struggle with. There are a number of barriers to care, and there are a lot of themes: lack of transition preparedness, challenges in navigating the adult system, especially if somebody has remained in the pediatric symptom into adulthood. It's a very jarring transition. I went to a talk on this by a provider specializing in transition age care and CP, and she had this incredible chart that a family had drawn out for her of how many people were actually involved in providing their child care. And it was actually dozens of people, right? So it's not just you're transitioning your primary care doctor, your psychiatrist, and your neurologist. You may have an enormous team that a family has worked years to put together that you're trying to transition into adulthood. It's nearly impossible for many families. Gaps in care are common, and let's face it, accessibility limitations to specialists and complex care environments is a real challenge. So I hope that I have walked you through just, if anything, a sense of the layered nature and interconnectedness of thinking through a single neurodevelopmental diagnosis. Somebody might come into your office with on their chart, they have a diagnosis of cerebral palsy. And for better or for worse, all of these things may be at play, and you need to be at least aware of or attentive to all of it if you want to be able to provide kind of holistic care to the person as a whole, if possible. So we've talked about integrating neurogenetics, management of conditions like epilepsy, understanding perinatal or early childhood injuries, comorbidities like pain, other disabilities, and medical comorbidities, and psychosocial and family health issues. So that's it. Thank you so much. Thank you to the faculty and administrative teams at Hopkins and at Kennedy Krieger, who I've just found endlessly supportive of this project in pediatric and developmental neuropsychiatry. Here's our neuropsychiatry team at Kennedy Krieger, thanks to Heather Reardon, with whom I co-designed a few of these slides. So I'd like to take some questions, please. Thanks.
Thank you, Dr. Hauptman. A lot of fantastic points and all kinds of really interesting issues you raised. I'll just echo one point as someone who's done genetics research and been a little bit involved in the policy issues around testing. It's very clear that developmental disability is the one area in psychiatry where it makes an enormous amount of sense to be doing genetic testing on a routine basis. Very interesting to see that you've just published that paper in that arena. So my question for you is, with regard to treating OCD in CP, is there a difference in how exposure therapy might be approached? I guess in particular I'm thinking of Joe McGuire and his virtual exposure concept. I don't know if that's relevant or whether there are other differences.
Yeah, I think it can be relevant for, I really appreciate the question. I think it can be relevant for a number of reasons. The fact that I think for many individuals, the nature of the kinds of, I don't know data on this. This is more from just clinical experience. But the nature of the kinds of obsessions or compulsions that somebody may experience, if they have mobility limitations, means that I think very often they are more internal compulsions or obsessions, which, as we know, can just be very different to treat than things that involve more rote, behavioral, external, like verifiable compulsions, right? It's much harder to know for certain what someone is doing in terms of an exposure that's entirely internal versus something where you can say, okay, we're getting, we are having you do this particular physical act and I can monitor that. So I think the room for virtual exposures could be really enormous.
Thanks.
Yeah.
Let's see if other folks out there have questions. Anything anybody has in mind?
While people are thinking about them, a second answer to your question.
Keep going. Sure.
We do have to think about medications a little bit differently. If somebody has an associated movement disorder like spasticity, we may really struggle with higher doses of SSRIs. So you may end up psychopharmacologically approaching it a little bit differently as well. So really being very attentive to potential iatrogenic issues.
Yeah, I was going to ask you about that one, actually. So I'm glad you answered it. So you may be, higher doses of antidepressants might worsen spasticity, and so that could be an issue. You have to be more careful.
Potentially.
Okay.
Yeah.
Okay. Other questions? Dr. DiPaolo.
Right, thank you for your talk. The question I have is really about patients I've seen who had occult neurological injuries, probably at birth, that we didn't recognize until maybe adolescence or later. And in a couple of those cases, they would have kind of catastrophic events that would knock them off their trajectory. One of the things that sometimes happened was that in some cases where patients got a neuroleptic, even a modest neuroleptic, antipsychotic, and had a gross deterioration of their mental state. Is that a familiar theme for you?
I'm trying to think. So it depends on which kind of injury we're talking about. There are certainly some where antipsychotic sensitivity is a real problem or a challenge. In my practice, we see a lot of people with like catatonia superimposed on neurodevelopmental disabilities that can often get dramatically worse with antipsychotics in some situations. So certainly, and I think it's going to be case or category by case or category. Yeah.
Thanks. Dr. Yue.
Yeah, I think from that study it depended a little bit. That was mostly focused on neurocognitive function. And it depended a little bit on which specific neurocognitive function we were talking about because it broke it down. But I think generally, people often think about like the first 2 years as an overall heuristic. But for some, it was a little bit later. But I would say within the first year or two.
Other folks? Yeah.
Yeah, so this is, I think, why we try to be so aggressive with workups when we have people like admitted within pediatrics or child psychiatry, you know, because there is this concern that especially if someone ages into adulthood, it's much harder to find a geneticist, it's much harder to find a team that's really going to dig into that. So if somebody has, let's say, cerebral palsy or like really significant autism spectrum disorder or dysmorphic features in association with intellectual disability, I would really push to get genetic testing, to get imaging. The yield can be pretty significant, but I know that it's hard to do, and it can be really hard to find people who do genetics, for example, around like neurodevelopmental issues, but who also are going to be available to adult patients. It's a huge problem.
Go ahead, Dr. Kronsberg.
Thanks so much for your talk. I was just hoping you could talk a little bit about either the need for or existence of like a specialized case management for individuals with some of the issues you described. In child motor treatment, we do a lot of work around service acquisitions and things like that. Neuropsychiatric illness, often the system programs exist or programs
Yeah, I really appreciate that question. I think it can be challenging for a lot of different reasons. It's often so specialized, and often the needs and the care coordination needs differ from diagnosis to diagnosis. So I think institutions handle these things differently in terms of trying to categorize developmental issues together, or whether somebody receives that care through a specialty clinic, like a dedicated cerebral palsy program. There's so many different ways to approach it, and I don't know that we have a single good uniform way, but you both sort of need to lump and split, which I think ends up being really challenging, right? Like everybody needs approaches to transitional age, but the details of that are going to differ from diagnosis to diagnosis, which I think makes for a challenging systems-based issue.
Mm-hmm. Dr. Berg.
When I think about like screening for depression, we think a lot about like physical symptoms and self-attitude. I'm wondering if there's like when you're thinking about depression in this population, where the physical symptoms might, issues with appetite or sleep or energy might be present always, right? Or issues with self-esteem. I know just from my friend with CP who always has like body image and self-esteem issues, sort of how to navigate. Is this part of a depression or is this just more demoralization? And how do you kind of piece that out?
Yeah. I think this is one of the things that makes screening really difficult. So this comes up a lot in so many different places, but even things like suicidal ideation screening, when you're working with patients who have an intellectual disability, understanding somebody's level of understanding of the questions that you're asking are really going to be extremely personally variable. And then I think it involves a pretty nuanced approach with, like so many things, sussing out what the person's baseline is and associated comorbidities, right? Understanding loss of appetite. If somebody also has gastroparesis or something, you're going to have to tease that apart. And so really, I think thoroughly engaging around their medical and neurological comorbidities and trying to contextualize those symptoms can make a big difference. Yeah, it's a great question.
I'm going to ask you one last question, which is with regard to this transition to adults. When I think about adult neuropsychiatry, I mean, they would be your obvious partners in theory.
Yeah.
And I think of them dealing with dementia, traumatic brain injury. I'm not sure I've ever heard of adult neuropsychiatrists being focused on developmental disabilities. Does that exist? Should it exist as a sub-specialty of adult neuropsychiatry?
Yeah, I love that question. Yes, obviously, definitely. Some of you should go into it, please. And there are places, I know, like University of Massachusetts has a fellowship, has like a specific fellowship slot that's dedicated to working with adults with neurodevelopmental disabilities. But they're few and far between. It tends not to be what people who it's so interesting tracing the trajectories we all go through in order to get to the spot we're at in medicine. And I think that you end up weeding out a lot of people with neurodevelopmental interests once they've gotten to that point and are much more interested in, I think, potentially more clear-cut diagnoses that we have, like, a very different level of understanding for. So I think it's something that we very much need, whether that should go through child psychiatry to then educate, like we do in our program, to then educate in neuropsychiatric diagnoses and thinking about the brain and more of a relationship that way, or whether you should go through adult neuropsychiatry and try to interest people and educate in neurodevelopment from there. It's 6 of one, half a dozen of the other. I think we need providers doing both. Yeah.
All right, great. Thanks. Terrific grand round.
Thanks
Appreciate
so
it.
much.